Good afternoon, and thank you for coming to this session on sorting the sequence in multiple myeloma, personalized choices with BCMA and non-BCMA immunotherapies in relapsed refractory disease. I'm Dr. Shambhavi Richard, Associate Professor of Medicine from the Multiple Myeloma Program at Mount Sinai in New York, and I'm joined by my esteemed colleague, Dr. Joshua Richter, also from the Myeloma Program at Mount Sinai. And together, I think we've planned an exciting program for you that I hope you'll enjoy and find useful in your clinical practice. Before we get started, I would like to thank the Medical College of Wisconsin and Peerview for providing the session, and Arcelex, Kite, AstraZeneca, Johnson & Johnson, and Legend Biotech for providing the educational grants for the symposium. Please look out for polling during the presentation. You can use your phone to scan this QR code on the screen once the question is shown. And if you send us your questions, we'll try to answer them during the Q&A session. You could also visit us at peerview.com/mmtandem26. You can view the slides and practice aids now and download them after the event. In the last 5 years, considerable progress has been made with BCMA and non-BCMA immunotherapies, starting with the approval of ide-cel CAR-T in 2021 and cilta-cel CAR-T in 2022, both approved for later relapse myeloma for 5 lines plus treatment. This was closely followed by several BCMA and a GPRC bispecific antibody. In 2024, we got the approval for ide-cel and cilta-cel for myeloma in early relapse for 3 lines plus and 2 lines plus. Last year, we saw the resurgence of belantamab, an anti-BCMA ADC, and another bispecific BCMA directed as well. And now we have some trispecifics as well that are in clinical development. So all of this rapid influx of immunotherapies have resulted in quite a crowded landscape for myeloma, and navigating through it can be somewhat of an art and quite complex. This is an analysis of the Flatiron Health electronic health record derived database of patients with relapsed refractory myeloma from 2011 to 2022, and showed that over 50% of patients who had refractory to lenalidomide and CD38 monoclonal antibodies were retreated with the same drug class, resulting in quite poor PFS and overall survival outcomes. In fact, for patients who were refractory to both lenalidomide and anti-CD38 antibody, the median progression-free survival was 4.6 months and the median overall survival was 19.7 months, highlighting the need for us to understand and for the appropriate usage of immune therapies, especially to take advantage of their alternative targets as well as mechanisms of action. During this presentation today, we will discuss guidelines and long-term evidence that support the use of BCMA CAR-T therapy in early relapse settings, the role of bispecifics in pretreated myeloma, and new data confirming a role in the early relapse setting, next-generation CAR-T options, including faster manufacturing and dual targeting, that show encouraging results in early investigations, and address practical aspects of care, such as planning for referral, CRS, ICANS, and infection management, and use of bridging and holding therapies to ensure effective delivery of immunotherapy in myeloma. So without further ado, let's get started on the road to remission in early myeloma relapse with standard of care CAR-Ts. We'll start with this audience poll question. Amanda is a 70-year-old woman with RISS to myeloma who was treated with Dara-VRd, then transplant, had dual maintenance with daratumumab and Revlimid, and went on to Revlimid maintenance. After 18 months on Revlimid, she progresses with biochemical relapse and will assume a good performance status and adequate organ function. What is your go-to strategy in this scenario? Immediately refer to CAR-T, CD38 triplet, bridge with a CD38 regimen, then proceed to CAR-T, daratumumab teclistamab combo, or I'm unsure of which pathway to pursue, CAR-T or a daratumumab teclistamab regimen. You can start voting now. And I see a So evenly split between immediately refer to CAR T or bridge with a CD38 and then proceed to CAR T. Seems like CAR T is the favorite, and then we have some of the others. Let's look at some data, and then we'll see if we can come back to that. So the current NCCN guidelines have recommended CAR T therapies for early relapse myeloma after 1 to 3 prior lines as a Category 1 preferred option. After one line of therapy for cilta-cel for patients who are IMiD and PI exposed and len refractory, as supported by the CARTITUDE-4 trial, and after 2 or more prior lines of therapy for ide-cel for triple-class exposed patients, and this is supported by KarMMa-3. These are the results from CARTITUDE-4 at a median follow-up of 34 months. To remind you, this was a randomized study for patients who had had 1 to 3 prior lines of therapy, and patients were randomized to CAR T with cilta-cel versus triplet standard of care options, DPD and PBD. And it met its primary endpoint with a significant improvement in progression-free survival. The median progression-free survival is not reached for CAR T, and 11.8 months for standard of care. The 30-month PFS was 59% for cilta-cel and 26% for standard of care, and the hazard ratio was an impressive 0.29. In addition, the overall survival is showing a significant improvement as well, with a hazard ratio of 0.55. And you can start to see that plateau in the cilta-cel arm at beyond 30 months of follow-up. A subgroup analysis was done on CARTITUDE-4, looking at patients with standard risk and high-risk cytogenetics. As you can see from the graph on the left, some things are immediately evident. First of all, cilta-cel does better than standard of care, regardless of whether you take standard risk patients or high risk patients. Secondly, as we intuitively understand that there's plenty of data to support this, high risk patients just don't do as well as standard risk patients, whether you do a CAR T or whether you do a standard of care option. However, what's interesting is that patients with high risk cytogenetic abnormalities who had a CAR T did better than standard risk patients with standard of care options, showing that doing a CAR T could actually overcome the negative effect of high risk cytogenetic abnormalities. Looking at the panel on the right, this is an analysis that was done by Luciano Costa and presented at ASH last year, looking at cilta-cel CAR T in patients with standard risk myeloma and comparing when CAR T was done earlier, as in CARTITUDE-4 with a median of 2 prior lines of treatment, versus CARTITUDE-1 with patients who had a median of 6 prior lines of treatment. And you can see the 30-month PFS was 81% for CARTITUDE-4 versus 60% for CARTITUDE-1, showing a greater benefit clearly for patients who had cilta-cel in earlier lines of treatment, even in standard risk disease. This was an analysis that was done by Samir Parekh at our institution and looked at biomarkers from peripheral blood as well as bone marrow tumor microenvironment for patients who were enrolled on CARTITUDE-1 and CARTITUDE-4, and correlating their overall survival by lines of therapy. And you can see that nice clear gradation in that overall survival, starting with 1 line of therapy in the red and 2 prior lines of therapy in the 2 from CARTITUDE-4 patients. The green shows 3 prior lines of therapy, and the blue is the advanced disease with 4 or more lines of therapy. So clearly, overall survival is better when cilta-cel is done with fewer lines of therapy, so earlier on in their disease. But interestingly, he was able to correlate the biomarkers and showed that this earlier improvement with earlier lines of therapy may be due to a more immune competent tumor microenvironment. These are outcomes from KarMMa-3. This is familiar to us. We had the analysis some time ago. The final PFS analysis at a median follow-up of 30.9 months shows that significantly longer PFS was maintained with ide-cel CAR T, with a median PFS of 13.8 months versus 4.4 months for standard of care. Hazard ratio was 0.49. Again, when broken up by lines of therapy, patients who had 2 prior lines of therapy and received ide-cel had a median PFS of 16.2 months, much better than those who had 4 prior lines of therapy and had ide-cel, and their median PFS was only 11.2 months. Further, a subgroup analysis did show benefit of ide-cel even in older patients aged 70 or above. Safety toxicities after CAR T in myeloma are unique to immune therapies. So let's spend a minute on them. CRS is almost universally experienced by patients, so 89% with ide-cel and 84% from cilta-cel on their clinical trials, mostly grade 1 or 2. The median onset, however, is different, 1 day with ide-cel and 7 days with cilta-cel, and these are product-related differences. ICANS is also not infrequent at about 18% and 13%, respectively, mostly mild to moderate as long as we address them with steroids or anakinra, etc., early on. Infections are a common problem after CAR T. These are highly immune suppressive modes of therapy. 61% and 57% was seen in the clinical trials, all grade infections, and 21 and 24% respectively for grade 3 or higher infections. Early on after CAR T, in the first 3 months or so, bacterial infections were common, and this was related to cytopenias post lymphodepletion. Later on, 3 months and beyond, viral infections are far more common. Fortunately, we don't see too many fungal infections, regardless of the product used. The most common treatment emergent adverse event following CAR T is cytopenias, early on, again due to lymphodepletion, but prolonged cytopenias can happen and can be a significant problem. Delayed neurotoxicity is probably the most dreaded side effect of CAR T. These are rare, with no consistent Parkinsonism signal reported with ide-cel. It's still rare, but distinct delayed movement and neurocognitive toxicities are reported with cilta-cel, including Parkinsonism-like syndromes. These are often of late onset and may be prolonged and not always reversible. Immune effector cell-associated enterocolitis is a newcomer to the toxicity seen after CAR Ts, but has made it into the black box warning in the package insert. These are rare, with an overall incidence of 1.2%, 0.2% with ide-cel, and 2.2% with cilta-cel. They may manifest as an intractable or waxing and waning course of non-bloody grade 3 or higher diarrheas, inability to tolerate PO intake, and can cause considerable morbidity and even mortality. The median onset tends to be at around 3 months or so post-CAR T. When patients are referred for CAR T, their disease is frequently in relapse. There are nuances to controlling disease at various phases of their CAR T journey. Prior to pheresis, the goals of therapy are to control disease without jeopardizing feasibility of CAR T cell therapy. So these are not standardized regimens. It generally follows what a patient is most likely to respond to while saving the T cells. Often used are PIs, IMiDs, anti-CD38 antibodies. We have plenty of experience at collecting cells and infusing CAR Ts after these regimens. However, the important thing is to avoid potent T cell toxins such as bendamustine, prolonged use of alkylator polychemotherapy, and T cell engager therapy. Bridging therapy is given after the pheresis and prior to CAR T infusion. The goal of this is to avoid clinical deterioration while reducing disease burden. Again, these are not standardized regimens. If you think the patient will respond to a PI, IMiD, or anti-CD38, these are probably the most predictable and least toxic. But for rapid disease progression, high tumor burden, etc., it is permissible to use the bendamustine, alkylators, or even T-cell engagers. When using T-cell engager, we do like to use an alternative target so that we reduce the risk of limiting their sensitivity to the upcoming CAR T. In terms of lymphodepletion, this is now a highly standardized and protocol-driven approach given right before the CAR T infusion, with the goal of inducing lymphopenia and facilitating a favorable cytokine milieu for the CAR T expansion. Fludarabine cyclophosphamide combo is the most commonly used, although there is some limited data for bendamustine, mostly generated at the time when fludarabine shortage was happening. It is important to remember to adjust drug doses for renal dysfunction, particularly for fludarabine. This is some evidence from phase 3 trials confirming the importance of effective bridging. Cartitude 4 is the panel on top and shows clearly the progression-free survival after CAR T by response to bridging. The top two curves, the black and the gray, are for patients who responded to bridging and had PR or VGPR or better. The people who did the worst were ones who progressed after bridging. And you can see that the 30-month progression-free survival for patients who had at least a partial response after bridging was over 70%, compared to 30% for those who had progression during bridging, and patients with minimal response or stable disease did somewhere in between. Karma 3 showed a similar kind of finding. Patients who had progression of disease with bridging had a median PFS of a dismal 6.9 months versus 20.7 months for those who did respond to bridging. In addition to their positive outcomes on PFS and OS, we also see lower incidence of fatal infections, delayed neurotoxicities, non-relapse mortality, delayed cytopenias, etc., with optimal bridging as well. So, key take homes for delivery of CAR T in myeloma: adequate planning and referral to a certified healthcare facility is required for collection of the patient's cells and administration of CAR T. CAR T in early relapse has better outcomes than in late relapse. Optimal bridging improves outcomes post CAR T. If possible, we do try to avoid prior line BCMA therapy, such as bispecifics or antibody drug conjugates, and use of prolonged use alkylators prior to pheresis. It's important to be familiar with CRS and ICANS management, with early use of tocilizumab, dexamethasone, and anakinra encouraged. Also, to be familiar with infection management, delayed toxicities, and second primary malignancies in long-term follow-up. So let's get back to our case. We have 70-year-old Amanda who is now having a rapid biochemical relapse on Revlimid maintenance after 18 months. She's good performance status and organ function. And the question is, do we think this patient is a good CAR T candidate, and when would be the ideal time to start planning for this? Dr. Richter, do you have something to comment?
Yes. Oh, no. So, we do a lot of talking in myeloma about risk stratification, about cytogenetic high risk and all that, but functional high risk to me trumps that all. If we look at the Perseus data, which is really kind of what this is mimicking, there's something like 17-year median PFS. If this patient is relapsing at this cadence, it's that old saying, the definition of insanity is doing the same thing over and over again and expecting different results. So if we've given novel agents and only received this type of response, going back to the novel agent bucket is not going to get the job done. I think it's time to move on to something like a T cell redirection in CAR T.
Agreed. And I think there's plenty of data now that shows that doing CAR Ts earlier on is better than doing them later on. You have more control over the situation, better options for low toxic regimens for bridging therapy. And we do see the improved outcomes with better T cell fitness earlier on than beating them up over and over with repeated regimens. Um, do we think is bridging or holding therapy appropriate for Amanda's case?
Yeah, absolutely. Especially if she's having a rapid relapse, I think that's the type of patient we're going to see some of the not only higher toxicities in the acute setting with CRS and icons, but maybe even more delayed toxicity and perhaps reduced efficacy. So, how would I approach a patient like this? At least to me, this patient is still CD38 sensitive. And if you want to hit someone harder, either DARA KD or ESA KD to me for a couple of cycles to get them to better disease control would be how I'd approach it.
Yeah, great. I agree. And also, I think this also kind of reaffirms the importance of earlier referrals to CAR T rather than later. I mean, we talk a lot about vein to vein time, time from pheresis to time of CAR T infusion, but there's a brain to vein time. From the time that somebody initially thinks of, is a CAR T appropriate for this patient, to the time where the CAR T is actually being executed. That could take over 3 months quite frequently. So, I think that again, I with more and more data that we keep getting, we have the advantage now of knowing this. We are now 5 years later since we initially started doing CAR Ts. We have understood a lot about handling the toxicities and how to, and it doesn't scare us as much to refer CAR Ts earlier on in therapy. Would you still pursue CAR T if high risk disease was present? What do you think, Dr. Richter?
High risk disease is present. I love these studies up front that kind of separate out people into 17P and 1Q. Once you've had at least one or two relapse, I don't really know what that means. So yeah, especially if the patient is high risk, they may not do as well as someone who has standard risk, but they're still going to do better as the wonderful data that you presented if they had standard therapy approaches.
Yeah, and I think again, high risk gives us even less time, even less of luxury of time to plan appropriate bridging therapy. It may not give us, the same kinds of time to plan the CAR T. And we know that these highly aggressive diseases and high risk diseases tend to mutate more frequently. They get resistant to drugs more frequently. So I think more importantly for the high risk patients is to for that timely referral for CAR T. Um, an allied question, is there a case for even earlier CAR T in high-risk myeloma? I believe we, have answered that. Um, so the answer is yes.
Either that or waiting for Carditude 5 and 6 to read out, and then we'll have, the next 35 years, we'll have a readout.
That was well possible. So to summarize what we did in the first session, this patient is a clear candidate for early CAR T based on functional status and early progression during Revlimid maintenance, and choosing a sound bridging regimen is important for successful transition to cellular therapy. I will hand the podium over to Dr. Richter now.
Right now in the US, there's somewhere between 5 and 6,000 places where you can get standard of care therapy. It's only about 127 places you can get a CAR T. So they're amazing. They're absolutely wonderful and maybe part of the path to cure, but we can't get it to everyone. So let's talk about bispecifics that we can, in many ways, get to everyone. So we have a polling question. Let's rethink Amanda's case. Now she's an RISS2 treated with quad, transplant, Dararev to Rev, but now she had a longer duration of remission, but she does relapse. She's now 79 years old, performance status of 2, declining functional status, increasing frailty. What is your go to strategy in this scenario? Refer to CAR T, CD38 triplet, bridge with the CD38 regimen, then go to CAR T, Daratech, or I am unsure what to do. That's why I came to this session in the first place. All right, so we got questions across the board. Oh, we have a lot of people voting for Daratech. So there's a lot of places we can go now in the early relapse setting. And myeloma is like a game of Go or a game of chess. Once you make that first move, the options become quite extensive. The question is, what are they sensitive to? What are they naive to? What are they refractory to? And bispecifics really have kind of been relegated to the end of the game, with CAR Ts really moving up thanks to Karma 3 and Carditude 4 to the early relapse. But one of the things that's very much changed this is the presidential voucher, now current listing of Daratech in the NCCN guidelines of Category 1, and the likely approval probably before this meeting is over. So this is the data from Majestic 3. And what I really want to point out is if you look at the lower line, Darapomdex, this is the most common standard in the US for second line. It represents about 10 to 12% of all prescriptions. This is what we're doing every day in clinic. And it's great. Don't let drop fool you. This does give us great outcomes, but it's a little hard to look at this and then look at this curve and not stare in amazement about relapse patients with a flat survival curve. It's absolutely amazing. And, and recognize there are patients we cannot take to CAR T. I think with auto transplant and CAR T, there is an age limit. Although age is a number, no one's taken a 103-year-old patient a CAR T. Same thing with autograft. But there is not a patient in the US that I can think of with the proper dosing, prophylaxis, and management that you can't get through a bispecific antibody. So the reality is, we have seen some flat curves in Carditude 1 and Carditude 4, and there may be some people even cured by those modalities, but access and patient applicability is still not universal. Both bispecific antibody based combinations, we can get amazing outcomes. Now, the next thing is CD38 utilization up front is rising in popularity. Although the majority of us are using CD38 triplets and quadruplets, at the current time, only about 20 to 25% of patients in the US will be CD38 refractory going into second line, but that's changing. That's rising because we're keeping people on therapy longer. And predictions are by 2030 that upwards of 50% of patients will be CD38 refractory going into their second line of therapy. So giving them a CD38 based regimen is not going to be applicable. Majestic 9, however, takes this into account. And I don't think this was filed yet, but is likely to be filed this month. This is similar to Majestic 3, except this is single agent teclistamab. And again, the early data so far is that this is extremely impressive. 40% risk of death, 71% reduction of risk of death or progression. This may be a new standard for patients in early relapse, CD38 refractory, but not eligible for CAR T. What about upfront? Because we're really trying to move, myeloma, you start off at the end of the road, it looks good. We move it to early relapse, looks great. What about upfront? And there's some fascinating data coming out from Majestic 5 and Majestic 7 with combinations like TechDR, TAL-DR versus DRD. And this is, again, something we love to see in myeloma, 100% response rate. Now, this data is amazing. It's extremely promising. But let's remember where the bar currently is for transplant ineligible myeloma in the US. Cepheus is a 100-month progression-free survival. Now, once we start combining CD38 and BCMA, the risk of infection definitely rises. Other malignancies may rise. So these regimens are great. There may be a select group of patients these are optimal for, but the bar is extremely high. What about consolidation? And again, I think this is another area where Goldilocks is really going to win out. One and done is probably not the answer for all. Continuous therapy forever is probably not the answer, but limited duration. So consolidative-based therapy after induction with a variety of platforms may be the answer to induce people into MRD negative or sustained MRD negative for long-term remission. This is data from the Sylvester group about the immunoplant study, looking at patients with newly diagnosed myeloma, irrespective of transplant, MRD positive, they get consolidation with BCMA bispecific. Amazing data so far. And most importantly, no deaths or relapses. So maybe the answer is not keep them on Rev forever or Dararev or even a CELMoD, but fixed duration consolidation. Very ambitious trial being launched by the Boston group, Determination 2. Of course, this follows Determination 1, which only took 13 years to publish. So we expect this publication somewhere around 3020. So please make sure you book your tickets for Tandem then. Very excited for this readout. But really what this does is kind of parse out how we view newly diagnosed myeloma. Standard risk MRD negative is a distinct group from patients with either residual disease after induction or high risk after induction, and really teasing them out into those that are negative, keeping them into fixed duration potentially, not treating them forever, or if they're MRD positive, do we still need a high dose melphalan, or can we give a consolidative approach with a bispecific antibody? All right, so where are we at right now? This is it. We got 2 CAR Ts, sorry, 2 so far, that's all you get. We have 4 bispecifics. We are twice as good as the CAR Ts, and they're really applicable across the board. Now, we call this tandem, and I don't see any tandem CAR Ts out there right now. Heel two-headed, very fancy, not really a tandem. Tandem bispecifics, that's where it's at. And this data has been presented now by a number of people is the Redirect 1 study, the combination of TEC and TAL. And if we look for extramedullary disease, some of the worst myeloma that there is, response rates with monotherapy have been about 30 to 40% with standard approaches. Not applicable. Not good enough, but we get close to 80% when we combine them. We have several patients on this study who would have been dead. Stem to stern myeloma, EMD, gone. So I think there are specific places, and now this is also listed in NCCN guidelines for utilization in specific subpopulations, particularly when myeloma behaves like myeloma, give it myeloma therapy. But when it starts behaving like leukemia, we need to think like PCL. And sometimes when it behaves like lymphoma or solid tumor, we need to up the ante. A little cheat sheet. So if you want to get your phones out to post on Twitter, this is a cheat sheet for the current TCE dosings. We have 4 bispecific antibodies currently approved: TEC, LRAN, TAL, and LINVO. The first 3 are sub-Q. The step-up doses are given every 2 to 3 days. Differences between TEC and LRAN, they're very similar data overall. LRAN's a little bit of a shorter step-up, and it's fixed dose as opposed to weight-based dosing. Talquetamab is obviously the different target with GPRC5D, FDA approved at the 400 and 800 microgram dosing level. And the new kid on the block from last July, linvoseltamab intravenous dosing from that data from the Linker MM1 study, very high response rates, around 71%. Step up dosings are done weekly, so as opposed to every 48 to 72 hours, is a step up dose on cycle 1 day 1 and cycle 1 day 8. Eventually gets to 4-week dosing after that. I think this room is probably very expert in the management of CRS and bispecifics. And again, CRS tends to be of lower grade and less intensity than with the CAR Ts, probably most specifically because many of us have already started giving prophylactic tocilizumab. And some of the amazing data presented by a bunch of the groups, including the Sloan Kettering group, has shown single digit rates of CRS when you give prophylactic tocilizumab. Once you start getting to need for supplemental oxygen or blood pressure support, it's really time to get the multidisciplinary team involved and get the ICU to get things under control. Uh, how do we win this game? It's not just about the efficacy. We recognize that, especially during the COVID era and even the post COVID era, we have patients dying in complete remission of BCMA directed therapies because of infectious complications. Keeping the vaccination schedule up to date is critical. Be proactive, not reactive. If you may or may not need a BCMA therapy in a year, no reason not to be up to date on your vaccines now. Make sure you get regular viral testing. Of note, things like HBV reactivation can be seen. CMV is seen quite regularly. I don't think we still know what to do with low-level asymptomatic CMV viremia, but important to follow. PJP and VZV prophylaxis are recommended, and if patient is at risk for HBV reactivation, and entecavir. All right, now I get to throw it back. All right, so this is Amanda. Now she's 70 years old, RASS2 myeloma. She gets a quad transplant, DAR Rev, now Rev. However, this time she has a much longer remission. She's on Rev maintenance, now has rising kappa light chain. She has a declining functional status. She's now performance status of 2. She's a bit more frail. Shambhavi, is this patient DAR refractory, or are you thinking CAR? Are you thinking bispecific?
So this is why it gets really important how we define what refractory is. Considering that this patient has been off DARA now for several years, presumably was responding to DARA at the time that she got taken off that treatment, definitely wouldn't consider her DARA refractory. So we'll take her as somebody who's still sensitive to anti-CD38.
So is this someone, let's say we go with one of my second rate bispecific antibodies and it works for a year or so, is CAR T ever going to be on the table for a 79-year-old performance status of 2, or is that never going to happen?
So that's a great question. And I think, fitness is a moving target, right? So we have somebody who is. Having said that, the older a patient gets, the more likely that the fitness is going to be an issue. We, I think, as a culture, don't like to look at age. I get that. But then an 80-year-old is still going to be an 80-year-old. Having said that, now I've done CAR Ts and up to like beyond 80, especially if we are using, judiciously using a low toxicity product. But one has to consider by the amazing data from Majestic 3, if the 79-year-old who's probably going to tolerate a bispecific a little bit better with this suboptimal performance status and fragility scores and things like that, she's going to be a lot older by the time she fails that bispecific. We also know from a lot of data that trying to do a BCMA CAR T after failure of a BCMA bispecific, especially if they've been on it for a while, we're talking exhausted T cells, we're talking, you know, definitely lower responses to the BCMA CAR T. So chances for a BCMA CAR T are looking less and less likely depending on what we choose next for the patient. And this is where the whole sequencing question gets to be an art and trying to like plan for the future while doing the best we can for the patient at this time.
So, I think one of the things that we have thought a lot about is now that we have the other target, we have GPRC5D. If we need to get someone to a BCMA therapy, exactly to your point, we're going to exhaust BCMA, we may affect antigen presentation. Is this somewhere where GPRC5D may be right for now to allow for control of disease, maybe improving whatever component of the fragility or the performance status is disease related to maybe get them to a BCMA product in the future?
And I think that's a great point as well, and an approach that we have frequently used. So this is a dialogue with the patient as well, because CAR T just has a whole lot more. in terms of infrastructure required, but also in terms of patient support and what their thoughts might be as to what they would look like next. Let us assume that this patient is someone who's open to a CAR T in the near future, understanding that we don't want to do a CAR T 5 years from now. So then a reasonable option is to do something like a GPRC, although she probably has lots of other options as well. But even if we decide to use a T cell engager, then we could do the GPRC 5D as a bridge to a BCMA CAR T, and that's something that we have done quite frequently. We do have to remember, however, that if she then does not do that well with the BCMA CAR T, we're coming back to these combos. But, and here's where it gets nuanced too, as to when we apply trial data. So if we're going to try to apply the Majestic 3 data for somebody who's now BCMA CAR T exposed and all these other things, we may not expect the same results, but it's definitely doable.
Absolutely. So, I think where we're at is this patient is not Dara refractory, which is going to be the majority of patients, at least in the US for the foreseeable future. CAR T is clearly in question given age, performance status, and with some of the amazing data, both in early relapse from regimens like Tecdara for Majestic 3, Majestic 9, and even the upcoming data for frontline therapy with the Linker MN4 study with lenvaseltamab, Majestic 5, Majestic 7. There may be a role for inducing a long enough remission upfront with older, frailer patients that may never need CAR T, may never need transplant, and may never relapse. And with that, I will pass it back over to my esteemed colleague, Dr. Richer.
Okay, so now let's cross the cellular therapy threshold and go to next generation strategies. I want to set the stage first with this Cartitude 1 long term results because these were pretty amazing. So remember, Cartitude 1 was for patients who had 6 median prior lines of treatment, very advanced myeloma. And this was a 5 year follow up and showed that approximately half the patients were still alive at 5 or more years. A third of the patients, mostly triple class refractory, remained progression free for 5 or more years following a single infusion of cilta-cel CAR T with no maintenance therapy. This was pretty amazing for patients, a lot of them who were intended for hospice at the time that this study was done, and made it into the New York Times. But have we arrived yet? I don't think so. We still need, there's always room for innovation to improve on what we have, to improve on toxicities. So here are some next generation CAR T strategies. We'll start again with an audience question. Which statement matches your thinking about next generation CAR T therapy in relapsed refractory myeloma, including faster manufacture and dual targeting options? I have no opinion. I'm not familiar with the evidence on next gen CAR Ts. Faster manufacturing comes at the cost of lower efficacy. Dual targeting strategies are promising, but more toxic. Next gen CARs appear to be highly effective and are well tolerated. Next gen CARs are effective, but not in BCMA exposed settings. So let's start the voting. So great. So a lot of people believe in next gen strategies. That's lovely to see. And let's see what the data says about some of these. So I'll start with anito-cel. Anito-captogene autoleucel is an autologous BCMA-directed CAR T therapy with a novel D-domain binder that's different from the usual single-chain variable fragments and that facilitates high transduction efficiency, CAR positivity, and CAR density on the T-cell surface. It's shown rapid and reliable manufacturing with less than 17-day turnaround time and a 96% manufacturing success rate. We have earlier results from phase 1 testing where anito-cel demonstrated a median progression-free survival of 30.2 months in a 4 lines plus relapsed refractory myeloma population. This is the study design of Imagine 1, the phase 2 study for triple-class exposed patients who had received 3 or more prior lines of therapy and were refractory to last line. After enrollment in screening, patients underwent pheresis, bridging therapy as needed, and then lymphodepleting with the chemotherapy with the standard fludarabine cyclophosphamide for 3 days, and then the anito-cel infusion at a target dose of 115 million CAR-positive T cells. The primary endpoint was to look at overall response rate, and key secondary endpoint was to look at the overall response rate in patients limited to 3 prior lines of treatment. These are the updated results for the 117 efficacy evaluable patients. The overall response rate was 96%, CR or better was seen in 74%, and VGPR or better in 88%. The median progression-free survival and overall survival were not reached, and the 12-month PFS was 82%. 24-month PFS was 62% with an overall survival of 83%. In terms of safety, 85% had any grade CRS, with no CRS seen in 15% of patients. CRS was grade 1 or 2 in 84%. Any grade ICANS was seen in 8%. There was one grade 3 ICANS and one grade 5 CRS event. This is the next product, AZD0120. This is a dual targeting BCMA CD19 CAR T product manufactured by the FastCAR Rapid Manufacture Technology. This targets the two antigens BCMA and CD19. While BCMA is expressed on the majority of malignant plasma cells, CD19 is expressed in low intensity on some subsets of myeloma cells and progenitor cells. The hypothesis being that if we can catch the myeloma cell prior to its differentiation into a myeloma cell, then we have a chance of perhaps eliminating the disease and decreasing the antigen-negative relapse rate. Manufacture occurs in less than 3 days for this product, really by enabled because of the elimination of the ex vivo expansion. So after activation and transduction, the entire expansion takes place in vivo, resulting in the generation of younger and fitter naive CAR T cells with a safety profile that enables outpatient administration and monitoring. This is the study design of the phase 1b Durga 1 study. Again, triple class exposed patients who had had 3 or more prior lines of therapy and PD'd with the most recent line of therapy. Prior exposure to BCMA therapy was permitted on this study as long as they had had at least a 6-month washout. After pheresis and bridging as needed, patients underwent the standard fludarabine cyclophosphamide lymphodepletion and the AZD0120 as a single infusion. 2 dose levels were tested on this dose escalation study at 1 times 10 to the 5 CAR T cells per kilo and 3 times 10 to the 5 CAR T cells per kilo. The primary objectives for phase 1b was to assess safety and tolerability and to determine the recommended phase 2 dose. Of the 23 efficacy evaluable patients, overall response rate was 96%, CR or better in 78%, and partial response in 17% at a median follow-up of 3.9 months. The median time to first response was 28 days, and responses deepened over time. 5 patients had a prior BCMA CAR T, and in this group, the response rate was 100%, and CR or better was seen in 80%, showing that at least in this small subset of patients, having prior exposure to a BCMA CAR T did not seem to negatively impact outcomes. Of the 17 MRD evaluable patients, 94% were MRD negative, and they all achieved negativity by month 1. It was a well-tolerated product. Of the 26 patients, 16 patients, that is 62%, had a CRS. 15 of them were grade 1. There was 1 patient in dose level 2 who had a grade 2 CRS. The median onset was at 9 days, and the median duration was 1.5 days. 46% received tocilizumab, and 12% received dexamethasone. In terms of ICANS, there was 1 ICANS event seen in a dose level 2 patient that occurred at 10 days and lasted for a day. So no delayed neurotoxicities, no Parkinsonism, cranial nerve palsies, or Guillain-Barré has been seen with this product, no IEC-associated colitis. Of the 26 infused patients, there was 1 grade 2 CRS and 1 grade 1 ICANS, with no grade 3 or higher CRS events reported. In terms of, there was 1 patient who had a grade 2 IEC-HS in dose level 1 that resolved within 7 days. In my car is a phase one first in human study of an off the shelf in vivo CAR T product. This is a KLN 1010. It's an off the shelf gene therapy capable of generating anti BCMA CAR T cells in vivo for patients with relapsed refractory myeloma after 3 or more prior treatments. 4 patients have been enrolled and infused on this study. All 4 achieved a partial remission and a MRD negativity by month 1. 1 patient had VGPR by month 3. And you can see the nice fall off of the serum free light chains at month 1 and the M spike and soluble BCMA by 3 months. All instances of CRS were grade 1 or 2, and there were no ICANS. Cytopenias were limited. They did see infusion related reactions, though, in 3 of the 4 patients. 2 were grade 2 and 1 was grade 3. So, beyond the first patient, all received prophylactic tocilizumab. Interestingly, persistent memory T cells were seen in all patients, showing phenotypic evidence of memory CAR T cell formation in blood after KLN 1010 treatment. And finally, this is the only non-BCMA GPRC5D targeting CAR T, arlocaptogen autoleucel or arlocel. Earlier results have been published after 3 or more for patients with 3 or more prior lines of therapy from the phase 1 study, and the recommended phase 2 dose was deemed to be 150 million CAR-positive T cells. This is the updated results from the dose expansion cohorts of 75 million and 150 million. The overall response rate was pretty similar for the 2 doses at 92 and 91%, and CR rate of 58 and 44%, respectively. The median duration of response was 16.4 months and 13.6 months in the 2 dose levels of 75 and 150 million, respectively. Rates of on-target, off-tumor, nail, skin, and oral treatment-emergent adverse events was similar at the 2 dose levels, and they were all grade 1 and 2, so better actually than the talc bispecific GPRC targeted. Another cohort of the study was for patients in earlier lines, 1 to 3 prior lines of treatment, and for this group of 31 patients, the overall response rate was 94% and CR rate was 71%. Of 16 patients with MRD data, the MRD negative rate was 75%. At a 15.8-month follow-up, the median PFS was not reached and 12-month PFS was 74%. Again, CRS, ICANS, infections, and nail skin oral toxicities were all grade 1 or 2. Others significant neurologic toxicities were seen on the study at 6.5%, and these were categorized as ataxia, gait imbalance, dysarthria, etc., so reminiscent of the cerebellar toxicities that we have seen with this particular product. I will stop here and we will go over this patient question. So this is David, a 72-year-old man, presenting with relapsed refractory myeloma, again with a good performance status of 1. His treatment history is a little bit longer. He had Dara-VRD in frontline, followed by transplant and Revlimid maintenance. He relapsed and in second line got KRD. His third line treatment was a CD38 and a PI doublet, followed by fourth line POM triplet. He now is progressed again, and assessment confirms well-preserved organ function. So what would be our standard of care option here? Would we go for a CAR T or a bispecific, Josh?
As an American, hello? Oh, there we go. As an American, I would say both, because more is always more. But the reality is he's going to get both in his lifetime. And the data says CAR T better than bispecific at the moment. So if you're going to get both, I'd rather give him a CAR T now and then a bispecific later, and then, 4 more trials of CAR Ts after that with 12 targets.
Yeah, I agree. And yeah, totally. I think that covers it. And so is there a role for CAR T in the context of a clinical trial?
Absolutely. I think Cartitude 1 showed us that with that modality, we are probably curing some patients, but clearly not all. There's still a gap that we need to achieve. And I think some of the data that you've presented with the AZ product, the dual target, I think dual target is probably the way to go when, more trials are needed.
Absolutely. Always a role for CAR T in the context of clinical trials, considering that we haven't arrived yet. And it's important to learn more. I think the field is still very nascent in spite of the rapid progress that we have made in it. So you did address the dual targeting CAR, and I assume that you are in favor of it, as am I. What if he had been exposed to a BCMA bispecific? Would you still consider CAR T for this patient?
Yeah, I think we're starting to understand that, antigen loss is not a universal thing. I think we need a lot more data on understanding BCMA mutational analysis. We know there's a number of bispecifics that have activity in BCMA mutated patients. So, what is the soluble BCMA level in the patient? What is the mutational analysis? BCMA does not have to be a one and done type of therapy.
Absolutely. And then, of course, we also have the GPRC CAR T. So we have, the advantage of having more options now, more targets. And I think continued research into finding multiple targets and multiple options is definitely important and already showing its impact on the improvements in survivals that we are seeing in this difficult disease. So, in summary and recommendations, so we agree that multiple options could be considered for this patient, including BCMA or non BCMA, including bispecifics or non bispecifics. BCMA CAR T therapy has shown the potential to induce prolonged PFS and overall survival in this setting. We do have the most data for BCMA CAR T products, so that's definitely, there's a lot happening in that field. Newer cars can be made faster, offer multi target potential, and may allow for more efficient and outpatient delivery. So, when we talk about the intensive infrastructure and things required, being able to do these outpatient would definitely open it up to more people and make it more acceptable to more as well. Great. So, one final poll. So, this is more of a reflection. So, what did you learn today? In which areas did you improve your knowledge and skills and select all that apply? Early use of CAR T is a standard of care, regardless of standard or high risk disease. Appropriate bridging is a key component of successful delivery of CAR T in early relapse. Daratech is a new option for relapse refractory myeloma and allows for subsequent use of CAR T or GPRC5D options. Next gen faster manufacturing or dual targeting CARs show promising efficacy and safety. We start voting. Great. So feel like this was a productive 1 hour. So we're happy to take any additional questions.
That was an awesome session. All right. And I told you I was going to heckle you after this. So here's my heckle. I have three things to heckle you about. One is when I see a patient that failed after 1 year after a car, 18 months after a car, 2 years, it doesn't matter. The first thing they ask me is,
Can I get another one?
can I get another car?
Yeah.
All righty. The quality of life
Yeah.
changes the perspective in my mind dramatically. Even honestly, even after a year they relapse, they just want to get another car, which is pretty amazing. So how do we get it to more people? My second question is, we didn't really talk about it, but should where does belantamab fit? Is it before any of this or is it always after any of this? And my last thing is can we all get together and and do the same thing? So can we do car followed by bite maintenance? Can we do, bite followed by car consolidation? What would you prefer?
Do you want to go first?
Sure. So the Mount Sinai team greatly appreciates the comments from the UCSF team. Um, Let me start. Belantamab, I think, is a very interesting drug, and there's some wonderful supplemental data from Dream 7 that at the time of maximal response, soluble BCMA levels were down, but at the time of relapse, they were back up again. And you're not going to get T cell exhaustion. So I think, although on paper it sounds like, yeah, we could use belantamab before these agents. I think that it's probably going to be more of a community approach. I think in the academic centers, we are using belantamab more in a phase where the patient still expresses BCMA, but their T cells may be exhausted and may not be optimized to attack it. In terms of what happens after that short relapse, one of the things I've seen with a couple people is, we still are naive in our myeloma thinking, as opposed to the lymphoma docs who've kind of figured out you treat CLL and DLBCL the same way. There are some patients where you hit them hard once, autograft CAR T, the disease goes away. But there are some patients that need that regular suppression. And I've had patients that blew through CAR T, and then we put them either on belantamab or a bispecific BCMA targeting, and that maintained them. So I think this requires more collaboration by Coastal to figure out who's who.
Yeah, agreed. So, yes, thank you as well, Tom. I think we know UCSF is the west coast of Mount Sinai, right? So, okay. But I think your first was a comment and completely agreed. Patients do love the quality of life after CAR T. I think if they've had a short lived response with the first CAR T, chances are with multiple CAR Ts, we definitely want something intervening as a sandwich to before we try another CAR T, and we want to make it something different. We don't want to try the same product. We want something that's going to be dramatically different, if possible, from the prior product. Definitely, in terms of belantamab, I think that we have evidence that CAR Ts that are done after belantamab just, it's the same as a BCMA bispecific. They just don't do as well. The responses are short lived. We have Adam Cohn's data from cohort C of that CARTITUDE-2. This is very telling data. So I hesitate very much to use these, especially if they are not going to give us the promise of long progression-free survivals reliably. Then it's better to do the CAR T first. And I used to say this for patients who came for transplant consults a decade ago. I say this for CAR T now. You're never going to be as young as you are today. So let's get that CAR T in, and then we can do these BCMA, other things that even frailer patients can tolerate. And finally, for the third one, I think like all the beauty pageants say, world peace. And there's a couple of questions that came in, so I'll read this out. For case one, where the preferred next step is CAR T, is there a reason why bispecific wouldn't be preferred? Is CAR T more effective than bispecifics for PFS and OS?
So I think it was just, Tom brought this up. It's really about quality of life. And even though CAR Ts are really not one and done, you're still coming for follow up, you're still coming for IVIG and all the supportive care. There is a great psychological impact of not being on chronic therapy. So even though when you start comparing things like Cartitude 4 and Majestic 3, and there may be certain facets that Majestic 3 comes out better, Cartitude 4 patients are off therapy for that time. So I really do like that type of approach early on for people that are applicable for it.
Yeah. And I think, again, coming back to the same thing, that sequencing now becomes more and more important. And there have been several studies that showed that CAR Ts prior to bispecifics do better than the other way around. So, again, I think it makes sense to try to get the CAR T in earlier and then to deal with the relapse after. Here's another question. Regarding the product AZD0120 characteristics, did the manufacturing use two separate vectors? Were both CD19 and BCMA antibody fragments located on the same single chain variable fragment or different? It different were they, sorry, if different were used, is those any data regarding the frequency of expression of each targeting receptor? So, in terms of the manufacturing niceties, I'm going to confess my ignorance on a bunch of these. I think that if I should not speculate, but regarding the frequency of expression, those studies are being done right now, and so we will hopefully have that in more in the next few. Hopefully, even by the next meeting.
Any additional questions from the audience? Well, then we'd like to thank you so much for taking the time to listen today and hope you enjoy the rest of Tanding.